Srikanth Shetty is going to speak on reperfusion in AMI. Focus on STEMI, optimizing management current thoughts.
Good afternoon, everybody. And first of all, I would like to thank Professor Nagaraj Desai and Dr. Prabhakar Koreval for this invitation. It's a privilege to address you all. I'm going to talk about reperfusion in STEMI, current thoughts. So we know that ST elevation myocardial infarction is a prognosis-altering event in the natural history of coronary atherosclerosis. So it is no small wonder that amongst the one therapy that changed the time course or improved survival amongst patients with cardiovascular diseases, in addition to coronary artery bypass surgery, has been the introduction of primary angioplasty and reperfusion therapy in patients with acute ST elevation myocardial infarction. We know patients can present either as a ST elevation myocardial infarction or a acute coronary event without ST elevation. But then we have to be very careful here in dismissing the significance of patients with chest pain syndromes at rest without ST elevation. I will come to that, about this new concept of what we call occlusive myocardial infarction without ST elevation. So here the classical teaching of how acute coronary syndromes can be divided into patients with no ST elevation versus those with ST elevation, wherein in the patients with ST elevation we pursue a need for urgent reperfusion. And the concept of time is muscle, because there is a ischemic wavefront which spreads from the subendocardium towards the epicardium, and with the time, with every passing minute, there is more and more muscle damage, such that eventually the infarction becomes transmural, and the benefits of reperfusion therapy become lesser and lesser, and the mortality and morbidity goes on increasing. So the underlying pathophysiology of an acute MI, we all know, is an occlusive thrombus on a ruptured plaque in one or more coronary arteries. Often the patient has more than one vulnerable plaque, so it's not just one location that the patient may have vulnerability. That's why, in addition to reperfusion therapy aimed at the culprit lesion, we also have to address the patient's vulnerability with aggressive pharmacotherapies as well. And what we do in the acute phase not only impacts the immediate outcomes of the patient, but because depending upon the size of the infarction, it also impacts late outcomes. So the remodeling, the expansion of the infarct, LV dysfunction, and therefore heart failure hospitalizations, and late mortalities as well. Coming to the diagnosis of ST elevation myocardial infarction, the classical teaching is this, that in two contiguous leads there has to be ST elevation. If it is lead 2, V2 and V3, the ST elevation has to be more than 2.5 millimeter in younger individuals, because we know some young males can have ST elevation less than that even without an acute coronary event. So more than 2.5 millimeter in younger individuals, more than 2 millimeter in individuals older than 40 years, and in all other leads, two contiguous leads should have ST elevations of more than 1 millimeter. However, we have this situation of what we call occlusive myocardial infarction without ST elevation, and some of those patterns which are recognized are, one is Valence A pattern, where you have biphasic T wave inversions in the mid precordial leads. Then you have Valence pattern B, where there is deep T inversion, and hyperacute T waves. In a patient coming with acute chest pain, persistent chest pain, it is important to recognize these, because these have the same implication. Most often these patients have neuro-occlusive or occlusive culprit vessel, and missing that can be catastrophic. So here you cannot wait till the next morning to do the intervention. You have to reperfuse urgently. Similarly, D Winter sign, which is upward sloping of 1 to 3 millimeter ST depression with a tall positive T wave. Then you have posterior in the anterior precordial leads. And then the challenges of recognizing acute myocardial infarction in patients who have background paced rhythm as well as those with left bundle branch block morphology, where you have to apply the modified Garbosa-Smith criteria to recognize acute myocardial infarction. So it is not always that a patient with acute occlusive myocardial infarction will present with classical ST elevations. You have to recognize these high risk patterns on the ECG as well, because these patients require urgent referral for reperfusion therapies. So when we talk about urgent reperfusion therapies, our choices are between either lytics or angioplasty. So we know there are several options. There are fibrin specific agents which are available now. The older agents like streptokinase and urokinase, while they are cheaper, they are associated with a very low probability of infarct related artery patency, less than 50%. That means you give thrombolysis with streptokinase, the probability that you reperfuse is less than 50%. So while those are cheaper, they are not effective. So if there is a situation where you have to lyse, you have to use fibrin specific agents like altiplase, retiplase or tenecteplase, because you are likely to achieve reperfusion to the extent of about 60 to 70% with these drugs. But the problem with thrombolytics is that while you don't need any special expertise and setups to give thrombolytic agents, they can be done anywhere. There are contraindications. Some patients cannot be given lytic therapy for those reasons, absolute and relative contraindications like I have mentioned over there, and these are all well known. And also the dangers of bleeding, particularly intracranial hemorrhages in elderly patients, which is associated with significant mortality. So you have two problems here. One is failed reperfusion and second is the bleeding risk and the contraindication. That is why the PCI, primary PCI for ST elevation myocardial infarction scores over lytic therapy, and this all started way back in 1982 with this trial by Hartzler et al., where they did this primary PTCA without intracoronary streptokinase. In fact, interestingly, the initial strategy for coronary reperfusion in acute MI was intracoronary lysis. So this was PTCA without intracoronary lysis for the first time in 1982, which opened doors for further studies like the PAMI trial, and then the meta-analysis of almost 23 trials of primary angioplasty, where the angioplasty was compared against lytics and on all parameters, death, reinfarction, hemorrhagic stroke, etc. Clearly there was an advantage of doing primary angioplasty as compared to giving lytic therapy. So when you combine all of these evidence-directed therapies like dual antiplatelet, beta blockers, statins and revascularization, you can significantly reduce mortality and morbidity in patients with acute ST elevation myocardial infarction. And after all the advances that have happened in therapies for acute ST elevation MI, one of the most important determinant for outcomes in acute myocardial infarction remains the time from symptom onset to treatment. So this is the most important determinant of 1 year mortality. So there are some important terminologies. One, what is called first medical contact. That is when a patient comes to a doctor with chest pain. It could be a clinic, it could be a nursing home, it could be a hospital without angioplasty facility, or it could be a hospital with angioplasty facility. It could be something inside the city, something outside. But from first medical contact to reperfusion, angioplasty particularly, it should happen within 120 minutes. And then there is something called door in and door out. If a patient comes to a clinic or to a hospital without an angioplasty facility, the door in, door out times have to be kept as minimal as possible, which means you all need to have protocols within your system, whether it's a clinic or a hospital, to identify people who come with chest pain, to triage them quickly, to do the ECG, to give the initial pre-medications, and then if you cannot lyse, if a nearby PCI facility is there, to shift the patient to there quickly. These decisions have to be made very fast. So that is door in, door out time. And once the patient arrives in the PCI enabled facility, the door to balloon time, these have to be kept lower than 90 minutes, whether it is during working hours or after hours or during holidays, etc., etc. And one of the most important contributors to prolongation of symptom onset to treatment is the patient's unawareness about the nature of his problem. So public education is a very important part of reperfusion strategies for acute myocardial infarction, so that the patient recognizes heart attack and seeks care. So as you can see over here, reductions in drug door to balloon time have been associated with reduction in in-hospital mortality over the years. So treatment for primary PCI has evolved over time. Initially it was only balloon angioplasty, then bare metal stents, then finally drug-coated stents. Drug therapies also have changed, like Dr. Keshav has mentioned. Our choices of antiplatelet drugs have improved. And the limitations of balloon angioplasty alone in acute MI is known, because you are disrupting the plaque. You may leave an injured vessel which can recoil, which can reocclude. So there were several trials which were done comparing stents with balloon and then drug-coated stents versus balloon bare metal stents, and then it has been concluded long ago that during primary angioplasty you should use the drug-eluting stents. But now again we are going back a little bit with this, a little modification of the strategy. Now there is evolving evidence of use of what are called drug-coated balloons in acute myocardial infarction. So it is still an exploratory area. There are studies that are coming up. It looks interesting because you can leave no metal behind. So there are studies like this which compared paclitaxel coated balloon versus second generation drug-eluting stents, and it has shown that in analysis of about 1,200 patients, there was no difference in all-cause mortality after an average of about 3 years between drug-coated balloons and second generation DES in patients with acute myocardial infarction. So DCB alone angioplasty can potentially be a safe alternative to using stents, but there are certain caveats to that. And what we have noted over time is that what we can achieve during primary angioplasty of acute myocardial infarction, that has kind of plateaued for various reasons, and further reduction in the drug door to balloon time has not seen to be associated with any further improvement in the mortality. There is suboptimal salvage of myocardium, reperfusion success only about 65% in terms of chest pain and ECG resolution, in part due to distal embolization and issues like reperfusion injury. Mortality continues to be high in patients who come with cardiogenic shocks, and non-culprit lesion related issues are also there. And as you can see, and as would be expected, the all-cause mortality and heart failure related hospitalizations will be higher if the infarct size is higher. And so myocardial salvage obviously is a very important consideration in treating patients with the acute ST elevation MI. Various therapies have been tried to improve myocardial salvage, but none of it has been found to be very greatly influential over there. And as you can see, the Horizons AM trial showed that whether you consider TIMI flow or myocardial blush or ST segment resolution, there is significant proportion of patients who have undergone primary angioplasty who still have failed reperfusion. And part of the reason is because of distal embolization, as you can see over here in this angiogram, and that leads to absent microvascular perfusion. And the impact of microvascular obstruction is that it increases all-cause mortality and heart failure hospitalization. And to deal with this, we have thrombectomy devices, either by aspiration or mechanical thrombectomy or using distal protection. But while these strategies seem to be mechanistically logical, they have not resulted in reduction of infarct size or improved, neither have they improved clinical outcomes. See, we can pull out chunks of clot like that, but that does not translate into a reduced myocardial damage. These days we also have powered clot aspiration systems like the Penumbra system. So, but there is not much clinical data on that, whereas while it is mechanically more effective than the regular manual aspiration systems. So this is how clot aspiration works. So pre-aspiration and post-aspiration, you can see the vessel is opened up, but when you look at the intracoronary imaging, there is still a lot of thrombus left behind over there. So aspiration trials have failed to show a reduction in the infarct size, and they have not reduced all-cause mortality and other MACE events. And they are associated with a higher risk of stroke, because you may pull the thrombus into the aorta and then it can embolize. So,
Dr. Shetty, kindly, can you wind it up in 2 minutes time?
Yes, sir.
Yeah, thank you.
Yeah. The last few slides. The other situation has been with revascularization of patients with STEMI and multivessel disease. So multivessel reperfusion in ST elevation MI has not been proven to be useful. There is no change in long-term outcomes, except that it improves urgent revascularization. Intracoronary imaging has been shown to be useful. IOS has advantages on OCT because it is quicker, you don't need to use too much dye, but in younger patients, if you want to distinguish between plaque erosion versus plaque rupture, you can use OCT, and if you demonstrate plaque erosion in a patient with an acute myocardial infarction, young patient, you can manage that patient conservatively without stent. So intracoronary imaging has all the advantages that you would see in a regular elective PCI. The same advantages you will also see in primary PCI. You have to also recognize this condition called MINOCA, which is myocardial infarction with no obstructive coronary artery disease, where you diagnose that with intracoronary imaging and cardiac MRI. In patients with shock, again, if you do multivessel PCI, it is associated with worse outcomes. In patients with shock, using mechanical circulatory devices, while it looks logical, has not been shown to improve the outcomes. Impella logically should have improved outcomes. The initial trials in cardiogenic shock PCI with Impella like ISAR shock, IMPRESS and IMPRESS in severe shock, they did not show improved outcomes. However, the more recent trial called the DANGER shock trial showed that all-cause mortality at 180 days is better in patients who received Impella assisted PCI as compared to standard care. So STEMI comprises approximately 25% of all admissions, and the case fatality rate is markedly decreasing, but it has kind of plateaued, and the standard of care is to achieve reperfusion as quickly as possible, particularly with primary angioplasty. Myocardial salvage is suboptimal in STEMI, and mortality remains high in cardiogenic shock despite the introduction of mechanical circulatory support system. Thank you.
Thank you, Srikanth. We'll have questions later.